So I actually know Dave and Sue, but I first met Dave, was it about 10 years ago, I think it was? Might be a little bit longer, I hate to say, when I was working at NHS England on patient and public participation. And it was the very first year of NHS England's existence. So that's showing my age, because look at, where we are now. And there's been a great deal of change along the way. From the impact of COVID, we've got a government with a very different approach, the rapid digital transformation of health and care. There's been a change in the infrastructure of local health and care systems. And very importantly, for today's conversation, health inequalities has worsened, exacerbated by COVID and by digital exclusion. So we've got a very different context to work with, I think, since we first met Dave. However, we've also got some really brilliant learning that we have all been involved in along the way. So our panels today are leaders in working in partnership with people and communities and service leads to improve services and lives, and in tackling health and digital inequalities, working at a local, a regional and a national level. And I think each of them have got really big ideas and big ambitions. And have a great track record of getting things done, which is important. So we don't have long to draw out all their amazing insights. So we're going to do a quick fire round of introductions first of all, and then we'll crack on with some questions from me. And I'm hoping that there's going to be time for a bit of a Q&A at the end, but we have got a very short amount of time. Let's get on with things. So Dave, do you want to start by introducing yourself?
Oh, hi everyone. This is really weird.
Yeah, it's weird.
I'm Dave Sweeney. I'm currently the Executive Director for Partnerships at Cheshire Merseyside Health and Care Partnership, which is another name for the developing ICS here at Cheshire Merseyside.
Sue, you're next. Hi Sue, you're next.
Hi, thank you. I'm Sue Lacey-Bryan. I work for NHS Health Education England, and I'm the National Lead for Knowledge and Library Services in England. There are 184 of those spread across the country.
Welcome. And over to you, Tero.
Hi everyone, I'm Tero Vanhanen. I'm Head of Design for NHS Digital. But you know, we are all merging into NHS England sometime this year. So I'm looking after all of our designers, interaction designers, service designers, and working very closely with our user researchers. And what we're doing is trying to, the national products and services that we provide, to make sure that they are useful, usable, accessible, and inclusive. So inclusion is very, very important to us.
Thank you very much. We're quite ahead of time, that's good. So, Dave, I can remember being really impressed with your pioneering work when you were working in partnership with communities back in Halton all those years ago. And I'm really looking forward to finding out, how you've applied that learning and also that energy for change at a wider regional level. So could you give us a bit of an overview of what you're up to in Cheshire and Merseyside and how the ICS is tackling that persistent challenge of health inequalities?
Yeah, thanks very much, Roslyn. Lovely to see you again. And although I can only see the backs of people's heads, I'm with you in spirit.
Are you over there? Everybody, give him a wave.
That's better.
You see their faces now.
And that is kind of the starting point and the proof of the pudding, because we're dealing with and we're working with people. That's kind of what we do. So that's never really changed from my original perspective coming into this line of work as a community care worker many moons ago, before I kind of climbed the greasy pole it was. And this is not a name drop, because it's not a name I would normally drop. But I was lucky enough to be in the Levelling Up debate yesterday in Liverpool. You may have seen it on the news with our friend Michael Gove, and we were the Metro Mayor Steve Rotherham of Liverpool, and the Mayor of Manchester, Andy Burnham. And the reason I kind of mentioned this just at this beginning point, whatever politics you're into, because it is incredibly important, politics, both with a big P and a small p, because most of our politicians, in fact all of our politicians who work in that local authority and wider growing ICS, because it's an integrated care system. It's so important. They look after their constituents, and many of the kind of post-bag stuff is around communication and the lack of knowledge of what's going on in terms of the new shifts and the new developments. One thing that was unified yesterday in that meeting was health inequalities, net zero, and the ability for the North to grow and to level up. It was a really interesting debate, and there was some really extremely important industrial people there as well, and looking at the kind of social value and looking at corporate responsibility as a whole. And we've got to do stuff different. We really do have to, take things by the short and curlies, and we can't be over reliant on central government all the time. Now, the power in that is people. The power in that, I've always found, is your best lobbyists are your communities. So here in Cheshire Merseyside, we have 17 trusts, we have 9 places. That's 9 sets of politicians. That's 9 local authorities working with one. It's going to become one ICS, one ICB, Integrated Care Board. So my job is as the kind of, if you like, the Kofi Annan of all of that, and to bring those connections together and to make sure there's harmony within that role, is to look for the hooks. So, and this is what I couldn't stress this enough. There's got to be hooks and there's got to be leverage. We can't expect our communities to get involved in stuff just because we want them to get involved in it. There's got to be a hook in it. Now, you ask any, I think it's 9 to 17-year-old at the minute, what keeps them awake at night? And it's the environment. The environment that's what most of our kids are worrying about, and quite rightly too. So I'm the SRO in Senior Responsible Officer in Cheshire Merseyside for the Green Agenda, and I cannot begin to tell you the interest and the hook that brings into our communities and partners across the board, because we want to save the planet. With all our green plans have come in from all 17 trusts, all local authorities, and we're bringing it together into one plan. The reason I tell you that is those of you, if you had to work across 17 hospitals and 9 local authorities and that huge conglomerate, being able to say that we're green right across the board, that we've ticked all those boxes, that we've got all those plans in, is amazing. Because it's like herding cats, like herding goldfish, seriously. Because there's a hook in there. There's a hook in there for everybody. So that then lends itself to another lever. So the Anchor Institute work that's going on, and I urge each and every one of you to have a good look at this, it's as a lever for your participation in terms of your communities. So what is an Anchor Institute? And looking at that, we've got the health innovation and a number of organisations have come up with some criteria, but what we're using is public criteria. The public are going to drive this. What does an Anchor Institute really do, and what is that going to give back into its community? So we're deriving that from the bottom up right to the top, say like social value, local jobs, net zero, maximising corporate responsibility. We estimate there's about 860 odd million, and I don't say odd because it is dirty maths, I'm no mathematician, a lot of money in untapped corporate responsibility. Now, as yesterday, and linking that together, if we can use industry in terms of that, and these are predominantly our local people who work locally in our local places, pushing that finance into just a number of small priorities. Each and every one of those industries and each and every one of those individuals that works in those industries are doing good. So if let's say we channel that into one of the major influences in Cheshire Merseyside, which is poverty and deprivation, and it'll be the same right across wherever you work. And we all work for the living wage. So we're determining one of those things in the Anchor Institute criteria is going to be you sign up to the living wage. We're putting extra money in people's pockets. One of the lovely things that Michael Marmot talks about, because Cheshire Merseyside is becoming a Marmot site, is the ability to take your family on holiday as a key evidential kind of outcome from reducing health inequalities. Now imagine if we can do that right across Cheshire Merseyside. Each and every individual who's been part of that is doing good, is doing their own part in terms of corporate responsibility. We're looking at pennies in the pound in terms of across our acute trust, so our staff giving a little bit, the odd pennies from the odd pennies that are in their wages back into that help and back into that living wage. So when I talk about that, it's an example of a strategic lever that was right in the heart of the communities, and every single individual that works in those industries or works in social services or works in health is part of the solution and part of part of that growth. And we're batting people away. The last webinar we ran around the idea of an anchor institute, there was 350 people on. The vast majority of them were from small businesses, from local people. And, I'll be able to say, as a kind of senior responsible officer of that we've asked the question. But we've not just asked a question because it's an NHS question or it's a local authority question. We've asked a question to our public to be involved in something that's going to radically change the lives of individuals in our community. And it's dead strong. So my message is, because I'm not going to take up too much of your time, we've got some brilliant speakers. My kind of tip and messaging into this, if you want to involve people, and I think we've done it, we have done it slightly tokenistically in the past. If we're going to involve people, there's got to be a hook and there's got to be leverage. So you're able to stir it anti-Meg from number 33 in Toxteth and say, by being involved, you're going to make this difference. And all of us, and I do this all the time now, because I've learned over time, if you don't have it, you miss out. You've got to have your elevator pitch. But what are you going to do? How are you going to do it? And when are you going to do it? And it's really, really, really strong. So environment, the Anchor Institute work, harness the policies that are coming down from the white paper, harness the stuff that's in there that really floats your boat, that that the public is going to be involved, that are going to be interested in. And, running of a big acute hospital, people are not that interested, to be honest. They go in, they get fixed, and they come out. And that's kind of their job. But in terms of, if we're going to be a truly integrated system and truly work together with our public, we've got to have those levers and we've got to have those, they propel people to be much more involved and feeling part of that, of the solution. Ross, have I got another minute?
Yeah, you've got a couple of minutes. Go on.
Okay. So I'm just going to bring that to life. So New Balance, they're based in Warrington, okay, and they're really good on their corporate responsibility. So I have to do all the due diligence checks and all the rest of it. When we have a social value award, and again, I can get all this information to you. So industry, local authorities, acute trusts can go for the social value award. It's a very simple, fairly simple mechanism, but it shows you have to prove what you're giving back to your community as a partner. And we're doing really, really well. We've got nearly 100 people and 100 industrial kind of partners signed up to this. But New Balance fancied it and they wanted part of it. So they gave 5,000 pairs of trainers, and they were kind of old stock, really good trainers, but they were last year's stock out in our most deprived communities. So I was able to go back to the board and say, here's the thing, if you follow Michael Marmot and you follow public health evidence, not only by giving those trainers out to kids, you're probably stopping bullying because they're not going to school with rubbish trainers on that they can't afford. Usually, we know how kids can be. You're avoiding sedentary behaviour by giving them trainers. You're getting people out in the parks and kicking a football or hockey, netball, whatever it is. And I can say with good evidence, we've got public health and back us up on this. By doing that, you're adding years to life. In fact, I would say you're probably saving lives. The whole board, you could feel the hairs on the back of the neck stand up, because it's not just a good thing fiscally or financially to do. It's a truly moral corporate responsibility rather than a corporate responsibility. And it just changed the landscape of how we're going about this. So you can say that, because that's evidence-based. And so we're building on that and building on that and building on that. And it's, we've got loads more to do in terms of inclusivity. There's a lady called a public health Edna. We recently won a HSJ for getting under the skin, and it was about inclusivity and diversity in that kind of communication. So we're trying to do as much as we possibly can. But anchor is my tip from today. My take home from today, have a look at that and maximise the community, maximise the local place input into that work, and you will reap the benefit of that a year, 2, 3 years down the line, promise you.
Thanks for that, Dave. And I think you're really showing us the true value of integrated care partnerships and systems and so on, aren't you? And also, I think you're showing us another important factor, which you haven't mentioned, which is around leadership, the passionate, authentic leadership, which you've just shown us there. You've also started talking about inclusivity, and I think that leads us nicely on to Sue's work. And we've sat on a few panels before, haven't we, Sue? So I know some of the sort of amazing stuff that Sue's going to come up with now. But you've got real expertise in health and digital literacy. You can't hear me very well, can you? I think. Can you hear me better now? You're on mute.
Can you hear me, guys?
Yes. Can everybody hear?
It's like a sort of 19th century seance, isn't it? Are you there? Can you hear me?
Should we give Sue a wave as well? Let's all give Sue a wave.
I'll wave to everyone as well.
There you go, Sue. Do you feel more part of the room? So sorry. So we've sat on panels before, and I know that you've got a real expertise in health and digital literacy. It would be really great if you could give us a bit of an overview of some of the challenges we face and some insight into, how can we overcome them, and any good practice and available supporting resources that you might have for us all to sort of pull upon and help on the sort of inclusion agenda.
Perfect. So absolutely great start. Always a joy to hear Dave speaking. And, I'm going to come in with, my elevator pitch is knowledge for healthcare. It's mobilising evidence, building and sharing knowledge, and improving outcomes. And what I'm going to do is put some questions to you that you can go away and mull over. And at the end of my speaking, there'll be a slide with some of the things that I refer to. So first thing is, do we understand our population? So connectivity can't be assumed, digital skills can't be assumed, and even if we had them, it wouldn't be enough. It isn't enough to talk about those things when we talk about inclusion. The NHS is looking for individuals, local residents, to use digital means to engage with the service, including via the NHS app, and to go to the internet to find and use health information and connect with services. So I want you to pause for a moment and think across your own family of people you've met through school, people you've met through work, and just get a couple of those in your mind and think about people who may be really quite challenged either to have access to digital connectivity, digital resources, or to people who may simply not have the skills to do this. I want you to think about people maybe clients and patients. So assuming you've all got a couple of named people in mind, listen to the rest of this, thinking about them and how far any of this applies. So 6.3% of adults in the UK had never used the internet. That's 2020 data. 10 million people lack the most basic digital skills, according to an infographic that's just come out from the Good Things Foundation, really worth looking at. That's brought together a whole set of really reliable sources from Ofcom, Lloyds Bank, Consumer Digital Index. 10 million people lack the most basic digital skills. And levels of health literacy in England are woeful. There is no other word. It is woeful. And I invite you to check out the levels of health literacy and numeracy amongst your working age population, the people that you're working with and serving, and use this information so that when we talk about the levelling up agenda, we really talk about some targeted interventions and base that on some evidence. In England, 43% of adults, that's 16 to 65, cannot understand word-based health information sufficiently well to make a decision about their health. And if you add numbers, that goes up to 61% who will be unable to understand and act on the information. Think about parents giving a Calpol dose, for instance. These figures are so shocking, people really often don't believe them. I'd strongly invite you to look at them and to remember that 16% of our population doesn't have literacy levels, is broadly illiterate. So there is a mismatch between the complexity of the health information materials we provide, the conversations we have with patients and clients, and the skills of adults in England. It's the same across Europe. And as Dave has already said, those in most need of health information are likely to have the least access to it, and low levels of health literacy are associated with poorer health and higher mortality. So I invite you to use that geodata. You'll see it at the end. It maps low health literacy or numeracy, and we are mapping it now to low digital connectivity. So that will be the next stage of that data. So that was number one, is what do we know about our population? Then what do we know about our workforce? So have our people got the skills they need to communicate effectively? And how are we looking to improve communication by health professionals with residents, patients, clients? So quick win here, because I can point you to a resource. It's some training that we've developed across England and Scotland, just 30 minutes. It's an e-learning program. And through that, we'll introduce you to some simple techniques to improve how we communicate and check the understanding of patients and clients. Techniques like teach back, chunk and check, how to use pictures, simple language. For NHS, for healthcare staff, building on that, we've a whole suite of training that we can offer to healthcare staff and partner organisations from NHS Knowledge and Library Services. So there are 184 of those, mostly in acute trust, but also in some community and mental health trusts. So worth checking where those teams are. And another way that they can help is to provide the evidence base for the patient information in the first place, so that we're really sure it's based on good evidence. And then help people thinking about the need to get that set in the right kind of formats to make it as accessible as possible. And, you know, really key to remember that digital inclusion will be an issue for some of our staff and our colleagues across the ICS, and the NHS libraries as physical places have got a massive range of facilities that will help members of the workforce who are really not able to access very easily from their homes. So that was the second question. What's the skill base of our workforce? The third is, how well are we working across our communities? Really follows on from what Dave has said, because of course we all want to appreciate the collective resources on our patch, and understand the assets available to our community. But do we really know who those people are and know who to reach out to in the way that Dave does in his community? So, you know, where are the public and voluntary services, community services? Where are the people who can signpost people to reliable health information? That has been a huge challenge for the entire part of my career. I started working on consumer health information when I first came into the health service. The pandemic has really shown to us the importance of being able to find high quality information. And we need a massive range of people being able to point to really reliable content. So public libraries, schools, receptionists, leisure centres, everyone. So have we got the people to build their confidence and capability to do that? And where are there local initiatives underway that could do with more coordination, more support, the warmth of glow of light upon the work that they're doing? So I wanted to share with you as a fourth point, be aware that there is a health and digital literacy partnership across England. My team from Health Education England is leading that cross-sectoral partnership nationally with the Arts Council and with Libraries Connected, which is the network for public libraries, and with the professional body from the Chartered Institute of Library and Information Professionals. That's a 5-year programme. We are looking to upskill information providers in many settings. We're looking to pilot different approaches, and we've just put out the first 16 pilots, and they are massively different. You know, some are looking at co-design of interactions with youngsters, young people 16 to 25. Others are looking at how we work with digital health, providing easy read content, development of online information, a whole series. We've got 16 different types of initiative so that we can start to make recommendations across the country around those. So look out for that and the information we share on that over time. The fifth point is really to ask how far we are upskilling people to be genuinely involved in shared decision making, and how far do we walk the walk? How far do we co-produce materials around inclusion? So if you're not familiar with it, there is a nice guideline on shared decision making from last June 2021, and it looks at making shared decision making part of everyday care in every health setting. Not anything very special if you've got something really racy, but something which is just part of how we work and do business. How to communicate risks, how to communicate benefits, consequences. So I can't stress enough how important that is, but also the value of co-production. And just as an example, we've been working alongside adults with learning disability for some time to produce an easy read document, so an easy read version of the knowledge strategy. We're working right now with people on the 3 questions that nice shared guidance says that we should all be using. You know, what are our options? What are the possible benefits and risks of those options? And how do we make a decision together that's right for me? And we're working now to get those expressed really clearly in easy read materials and in visual materials.
Sue,
and then my last plea, as you'd expect, is use the evidence base. It's nothing new about the work we're trying to do. There's nothing new about the fact that much of it has not been hugely successful over the 40 years of my career. I beg you to learn from previous experience and use the evidence base. There's amazing work going on right now, and ask your Knowledge and Library Service to do a search on it. There you go.
That was an absolute masterclass, I think we'll all agree. Incredible. Thank you so much, Sue, for all of that wealth of experience and information and wisdom. Really appreciate that. And now I feel like we've got a microscope and we're sort of turning it around and looking through different lenses at the challenge today. And I'm turning it around again, and we're going to get Tero to sort of stand back really a little bit and talk about, you know, what's happening at a national level, what are the plans and what's going on and what is the thinking around user-centred design, which will help us on the ground to tackle some of these things that, you know, that Dave and Sue have been talking about.
Thank you. How long have I got?
We've got till 20 past. If you could finish a couple of minutes early, we might squeeze a question in if you can. Thank you.
Thank you, Sue and Dave. I think that's brilliant to hear that. And as a part of the national service provider providing lots of national digital services, I feel somewhat guilty listening to that. But I think that's absolutely right. What we should be doing as a national provider, we should feel guilty about not paying enough attention to that inclusiveness and making sure that we provide services to everyone. And we need to look into ourselves at what are we as national providers are doing. So, and how do we work with, for example, with ICSs and local service providers to really connect with the people that we are providing services for. We are often looked at, we are in the cloud sometimes, and lost the touch with the reality in a way. And the way for us to get back into that is to work closely with ICSs and local service providers. And I think that's why the merger that's now happening is a great opportunity. We can actually start looking at how do we provide services, how do we work closer with, not just looking at the kind of digital services in isolation. I think Dave was talking, both Dave and you were talking about the health, the literacy and how the access to digital tools and people don't have the access to that. In the previous panel discussion, we discussed about even if you have access to tools, you may not be afford to put money onto your mobile phone to actually use that for example. And there's all these different things that we just need to look at when we provide services. NHS app gets mentioned all the time, and again, it's seen as the kind of one of the front doors to the NHS, and it does great things. In some ways, it can increase the inclusiveness because those people who don't have access to healthcare, they can use digital tools. But we also have to understand that it's not for everybody, and this is where really the service design comes in place. We need to look at how do we design services and not just apps? How do we provide outcomes to people that help them to manage their healthcare, and not just looking at one individual kind of a feature or channel and way to do that? Service design is all about ensuring that the people and the users of that service have a choice. How do they achieve the goal? How can they get to that? Some part of that might be digitally. Some part of that might be physically. Some part might be telephone. Some might be that they need somebody else to help them with. How do we provide them the tools that all of that is possible so that they can choose in which part of that journey they might be able to use digital or none at all? And it's the third time I'm going to quote the NHS Constitution today, but since I got it in front of me, I may as well. And it really is that the first principle is that the NHS provides a comprehensive service and available to all. And specifically, it says to pay particular attention to groups or sections of society where improvements in health and life expectancy are not keeping pace with the rest of the population. And again, that's what both Dave and Sue are talking about, that's about equity. That's creating equitable services. We talk about that in NH Digital, and we talk about it's almost going beyond the inclusive design. This is about looking at, well, who needs that support more, and how can we provide the support so everybody can have a fair chance and same opportunities to get the healthcare that they need. And we really need to understand that. Fascinating day, we were talking about sustainability. Again, that's a big thing, of course, for the whole NHS, looking at how can we do that. What does that mean in terms of us designing services? We are very much looking into the designing for sustainability. It's also in the International Standard for Human-Centered Design, ISO 9241-210. It says that user-centered design can enable sustainability. And it's true, because when we design things that are useful, usable, accessible, and inclusive, that means people are using them. There's nothing less wasteful than building and developing services that nobody will use. We wasted time and money to do that. So sustainability is in that way a big thing. And I really like Dave was talking about having that hook. It reminds me of asset-based community development, which is how can we use the communities to help them to define and develop their own healthcare. And of course, there's the clinical safety aspect, which is slightly different to that, but there's definitely things in there that we need to look at. And again, I'm reflecting that as a national service provider. What does that mean to us? How can we do that? How can we get better to that? And that's having access to ICSs and working closely with ICSs. Forming these service design teams that actually cut across the boundaries of national, regional, local. Why can't we design things together? Why do we have to have these boundaries? And that's really what I imagine that this new merger will help us to do, that we get closer to look at that in a more holistic way. So, what are we doing then on a national level? We have, at NHS Digital, we currently have about 90 designers. We have about similar amount of user researchers and roughly same amount of content designers. So we have a sizable team looking at this in a national level. And we're hoping to increase that. We're, of course, merging. There's more people joining our communities, and we look at what does that mean? What are the best practice? We have lots of standards that we're looking at. We have our design principles. We have our service standards that we're following. And we have, of course, our service manual, where we are looking at what are those, the guidance and the tools that currently really it's aimed for designers. How can they use those tools to create better designs in the system? What we want to do is look at the service manual in a way that, well, how can we add more things to it that enables anybody in the system to use the tools and the techniques and the helpful advice in that service manual to start designing useful, accessible, inclusive services. Because the reality is that we can never hire enough designers to cover the whole system. And really, that isn't the point. What we need to do is look at, well, how can we change the culture? How can we get the design thinking, which is really a process of following steps and kind of doing certain things. It's not any kind of magic thing that we do as designers. We facilitate the process, and we're more than happy to facilitate teams through that process. But it's something that we want more and more people to understand. How can we use that? How can we start looking at those techniques and those ways of working to start designing things in a more user-centered way? What are those things? We are then looking to how can we provide that support from national level. And that's what we believe, that that's something that we can do. That's our place, is to help ICSs and regional levels and local levels to do this work. So within this merger, we are looking at how can we support that. Simon Dixon, who's the Deputy Director for Use and the Design in the ex-NHSX world, now we're all in the NHS England, he's looking at how can he start supporting by providing experts into those regions and local areas to help to start to initiate that conversation. But again, that doesn't mean that we're going to just come in and we're going to rule it all. We want to bring people with us. We want to help you to make your teams to more user-centered and start designing these things yourself. But that's happening at the moment. Like I said, we're putting more stuff in the service manual, and that's going to grow. But at the same time, we also wanted to have that conversation of regional local teams. Is that, so what help do you need? How can we help you? How can we help you in a way that we can help you, that you can't do? But at the same time, what should we stop doing? Because that's much better done by you in regional local areas.
Thank you very much. I'm afraid we have run out of time. I'm a terrible chair. But I just want to give all three of you the chance, because I know, I don't know about you guys, but I would really like to ask you lots of more questions. Is there any way that we can get in touch with you or ask you questions or find out more about your work? Do you want to go first?
I can do. So I'm rather unique. You can find me on LinkedIn. You can find me on Twitter. Go and find me. Do ask questions. If you got any questions about how can you get in touch with about the regional offers, you can also use our email address ucd@nhs.net. And I will. Simon Dixon was meant to be here. Unfortunately, he couldn't. I will make sure that he gets those messages that are related to that work. So Sue is on Twitter. She's Sue Lacey Bryant on Twitter. So that's pretty good. And there's her email address, so get your cameras out quick. But it's sue.lacey -bryant @hee.nhs.uk. And Dave, how do we find out more about your fantastic work too? You're on mute. Yep.
Yeah, sorry, I was checking my my Twitter, but I wasn't quick enough. I wasn't as quick as Sue. So I'm at Dave Sween, 1969. On Twitter. That's got nothing to do with my age. Might have. And I'm dave.sweeney1@nhs.net.
Brilliant. Thank you so much, all three of you, for that really amazing sort of set of completely different sort of but aligned masterclasses. And I think sort of to me, the one big thing that came out was about listening, listening with intent to understand, to people who we're here to serve, basically, and also to focus on outcomes. Digital is not the end, it's the means to the end. And it's a useful enabler, but it's not what we're here to do. So thank you so much, everybody, and thank you for listening. And I apologise for not leaving enough time for questions. We could have spent the whole half day, couldn't we, on this, I think. But thank you, everybody.